Thank you for joining us today for our program, ARIA Reports, Notifiable Diseases, and State-Purchased Vaccines. If you have any questions about anything being discussed today, please call or email during our broadcast. The phone number and the email address are on your screen now and will appear again later in the program. Also, the handouts are available online. You will need to register for this program in order to access that material. I'm Dr. Karen Landers, Interim Assistant State Health Officer for Disease Control and Prevention and Area 1 Health Officer with the Alabama Department of Public Health. And with me today is Betty Helms, Administrator with the Immunization Division at the Alabama Department of Public Health. Welcome and thanks for joining us. The information that we are going to discuss today is going to relate specifically to policies in the state of Alabama. There are no CEUs for the information that we will be providing today. And with that, we would like to go ahead and proceed regarding the information on ARIAs, suggested solutions, notifiable diseases, and ordering state-funded vaccines. When we're talking about administering vaccines to patients, as I just had a very prominent physician say to me yesterday, if we don't do it right, it doesn't help the patient. And that's what we're all about, and that is helping the patient and ensuring that the patient receive the maximum benefit from administration of a vaccine. Now, we can talk about the effectiveness of the vaccine. We can talk about the individual patient's immune response to the vaccine. We can talk about many concerns that patients might have about vaccines, but that's really a topic for another program. What we want to talk about today in doing this right is giving the patient the correct vaccine in the correct manner. So when we're talking about the rights of medication administration, I have to go back to my training as a physician very, very early in my career, and that is ensuring that we are giving the medication, or in this instance the vaccine, to the right patient. It's not sufficient to walk into the room with a vaccine and administer the vaccine without verifying that the person that you are administering it to is indeed the person that is intended to receive the vaccine. And just an example, in my career, I was trained to look at the name of the patient before I went in to see the patient. Once I'm in the room with the patient, verify that that patient is who they say they are. I know that in the hospitals now, we look at the hospital bracelet and we verify that that is the patient with their information on there. But again, for us, we want to ensure that the right patient receives the right vaccine. And how many times have we had children with names that are slightly different? I had a set of twins as patients a couple of years ago, and there was one letter in the name that was different, one letter. And I asked the mother why she named them that, and she said they were twins. And I said, well, yes, identical, except for the name. So again, that was a little bit of confusion. So we want to ensure that the right patient, the person for which this is intended, receives the medication. Now, talking about the right medication, well, again, it goes without saying, the vaccine that that person is intended to receive that day. Certainly, we endorse the policies and we endorse the information from the American Academy of Pediatrics, the Advisory Committee on Immunization Practices. We know what vaccines are intended for what patients and what vaccines should be given on certain schedules. But again, in looking at what that patient needs that day, we can look at multiple sources. First of all, we're looking at the patient's age. What is age appropriate for that child? We're looking at the patient's vaccine record that is in front of us, the information that we receive from our imprint system, our registry. Also, we're looking at, as part of our imprint, the vaccine forecaster. So what vaccinations are that patient supposed to receive in that day? So we want to make sure that we give the medication that is intended to that patient. And this can go further, and it should go further, as we are looking. Not only are we verifying what that patient is supposed to receive, but once we pull that product from our refrigerator, we want to look at that product, look at all the information on that product prior to that administration. For example, let's just take a vaccine such as measles, mumps, rubella. When we pull the vaccine out of the refrigerator, is this measles, mumps, rubella? We're verifying that it is MMR. Is that vaccine in date? Does that vaccine have, again, a date that is still, viable? Or has that vaccine been expired? Well, it shouldn't be in the refrigerator if it's expired, but nevertheless, look at that vaccine, say this is MMR, this is the date of expiration on this vial, this is correct for this patient. So we've verified that that product not only is the product that has been ordered for the patient, but that the vaccine is in date, that it is still appropriate to be administered. And I do have instances, and we'll talk about this in just a moment, where a vaccine was expired a day before it was actually given. Well, unfortunately, if it's expired, it's expired. There has to be a date on there somewhere, and, while there might be some argument about that, if it's expired, and we have to repeat that, and that's not something we want to do. So, again, is it the right medication for the patient? Is it what has been ordered for the patient? And when we pull that product, is it the correct product? Now, there are other nursing parameters that you all go through in ensuring when you're administering medication. But again, I remind myself, the right patient, the right medication. And what is the right dose? Well, again, with vaccines, we have prescribed doses that should be given to the child or the adult. So let's look to ensure that what we pull up, if we don't have a pre-filled syringe, personally I like pre-filled syringes because I think that makes things easier. But if not, if we're having to pull this up, are we pulling up the correct dose for that patient so we can ensure that that patient is receiving what is recommended for that product? The right route. And this really can't be understated because we know that vaccines have to be given in the correct route in order to be effective. So a vaccine that is supposed to be given subcutaneously should be given subcutaneously. A vaccine that is supposed to be given intramuscularly, again, should be given intramuscularly. And the reason for that being that that relates to the effectiveness of that vaccine. Plus, we know if we give an intramuscular vaccine subcutaneously, that person can have a sterile abscess to occur or some other unexpected reaction. So we don't want to give the vaccine in the incorrect route. And again, through the years, some of these recommendations have changed, but we need to be familiar from our protocol which route is correct for the patient. And I will refer periodically in this talk to the pink book. The pink book, we have the red book from the American Academy of Pediatrics. We have the pink book from the CDC. The pink book has an entire section talking about vaccine administration, vaccine safety, vaccine handling, routes of vaccine, how long the needle should be, what size needle based upon the weight of the patient. This is all exceedingly important information. It's very helpful information. We have this information readily available not only in our protocol but also in the pink book, and we want to ensure that we give the medication correctly. It is extremely important that we use the right route. The right time, well, again, perhaps, one might say, well, this might relate more to medication that is given on a periodic basis in a hospital setting or in an outpatient setting. But my statement about right time means also, is this the time the patient's supposed to receive the vaccine? So again, it just really goes back to the right medication, but also the right time. Again, just a double check. Is this when the patient is supposed to receive a vaccine? We don't need to be giving vaccine that has not been approved for the age group that we are administering. And also, again, many of us have been taught, as I call it, the 5 rights, but There's other information that I like to remind our staff that is extremely important, and documentation. Just to go back to, if you don't document it, you didn't do it. Even if you did it, if you don't document it, if there's no record, then you did not take that action. You did not administer that vaccine if we don't have it documented. Now, as you all know, we're working very, very diligently with the registry, getting our information into our imprint, asking our outside providers to get information into the registry so we know that patients have received a vaccine, so that the vaccine will not be administered twice. For example, if we don't have that information and a person presents to us and they need a vaccine, then if they can't produce that information, then we're going to go ahead and repeat that vaccine. So if the documentation is there, we don't have to have the person receive a vaccine unnecessarily. Now let's talk about the right reason for administration. Again, this really is just a reinforcement of the other rights. But again, what is our reason for administering the vaccine? Well, our reason for administering the vaccine is to ensure that that patient receives that vaccine product in the appropriate manner to stimulate that person's immune system to develop immunity, to develop antibodies to that agent. And we all know that vaccine is one of the most important developments in public health of the 20th century. Think of how many people's lives have been saved as a result of taking vaccines. And then again, the right response to medication. We all know that there are individual responses to medication that generally are not expected. It's very rare. People sometimes do have a reaction to a vaccine product. It's extremely rare, exceedingly rare. And, just to remind ourselves, vaccines are far safer than the diseases that they are designed to prevent. So again, just an example, I was in a meeting this morning, and measles vaccine was part of that meeting, and I reminded myself, back when I was a child in the 50s, of the situations where I just knew I was going to get measles. I'd get measles. My mother would darken the room. The several days. Next thing I knew, I came out of the room. I'd get mumps. All the things that kids were going to get at that age. Parents just expected that. But also remembering that at that time, people died from measles disease. And I remember one of my earliest recollections of childhood is my brother being rushed to the hospital as a result of having measles pneumonia. Now, my brother is almost 65 now, so the good news is he did quite well. But this is an era when we didn't have a lot of antibiotics. He was quite sick. He was quite sick for a long period of time. So again, one of my early recollections is of my brother being ill and being a little child and being worried about how my brother was going to do because he went to the hospital. So again, the right response. We want to vaccinate children in order to reduce these deadly diseases. Now let's talk about opportunities for improvement. Again, our goal is to have 0 reports for vaccine administration errors. That's our goal. Our goal can be reflected by looking at where we can make improvements. So what are our opportunities for improvement? Well, one of our opportunities is expired vaccines should not be given. And the vaccine date is on the vaccine vial. The date is on there for when that vaccine expires. That vaccine should not be given. We can take many measures to reduce this situation with expired vaccine, and we'll talk about those a little more in a moment. Incorrect vaccine being given. Again, we have our vaccine forecaster. We also have our information related to the child's age. That's in our protocol. We have our information and our knowledge related to the record that we have perhaps in front of us in addition to our vaccine forecaster. So we know which vaccines should be given. Additionally, it gets back to those rights. If a person comes in for a meningococcal vaccine, they don't need to get an MMR unless they have a need for an MMR. Both vaccines start with M, but they're certainly not for the same thing. So we want to make sure that the patient, if this is what's ordered, this is what is given. We want to give the correct vaccine. And we'll talk a little more about that in a moment. And again, opportunities for improvement. Now, I put vaccine adverse reactions here simply to remind all of us that we do need to report information related to a potential adverse reaction for vaccine, because that gives us an opportunity to, first of all, verify if that indeed is related to the vaccine, but also an opportunity to keep data related to adverse reactions. And where this data was really important is, we remember back several years ago with the rotavirus vaccine that was previously out before the new rotavirus vaccine has been out more recently. But there was an increase in intussusception after the rotavirus vaccine. And of course, that vaccine was removed from the market, and further advancement and further scientific investigation was done, and we now have a new rotavirus vaccine. And again, looking just recently at the rate of intussusception up to 8 weeks after rotavirus vaccine, it's extremely small. And again, the overarching concern is that the rotavirus vaccine still prevents a lot of morbidity and in some cases mortality. I mean, a very young child that contracts rotavirus becomes extremely ill, vomiting, diarrhea, dehydration. That child can develop much more significant problems and even die. So again, the risk of intussusception is far less than the risk from having the disease. But again, we still need to be aware of adverse reactions, which again, vaccines are very safe and adverse reactions are exceedingly small, but have opportunities to report those, and we have a system for reporting vaccine adverse reactions. So we'll talk about incidents. And again, expired vaccines. Well, we had 5 incidents this past year with expired vaccines being given. And this is a problem that we can correct. 3 incidents of vaccine expired by 1 to 3 days. 2 incidents, vaccines expired by a longer period of time, over a month. Now, again, our opportunity there, we go back to our rights. If we look at our rights, we know that when we are getting ready to administer that vaccine, when we pull that vaccine, we're going to look at that vaccine, we're going to look at that product, we're going to look at that packaging, look at that vial, and we're going to check that expiration date. If that expiration date is not in agreement with when we're administering the vaccine, then we won't be administering it because that vaccine is expired. And again, I go back to, if it's expired for a day, we still have to administer the vaccine again. We still have to give it. So look at your product and ensure that you're not giving a vaccine that is expired. And we've also had a couple of instances expired vaccine older than a month. And we're working diligently with the nursing staff on a regular basis, and I think it's extremely important that we all work together as a team, our immunization team, our nursing teams out in the counties, to ensure that we reduce the risk of an expired vaccine being given. And one of the ways to do this is to make or have certain persons in the office that are responsible for rotating the vaccine. I never like to see a vaccine go to waste. I never like to see a vaccine expired. And I think if we rotate our stock, that's one way that we're going to reduce our risk of having a vaccine expired. We're going to be giving the product first that is most likely to be expiring soon, and then that way we won't waste a product, because these products cost money, and we certainly want to be good stewards of the funds that are involved in purchasing these vaccines. But additionally, if we have expired vaccine and we're waiting to dispose of that vaccine product, that needs to be removed from the vaccine refrigerator. It's no longer in date. It's no longer able to be administered to the patient. So let's get it out of the refrigerator, and that will just make that much less likely that we would have an incident to occur. So again, those are suggestions that come from the staff. And as I was speaking with some staff members a few moments ago, one thing that we have to all remember is we all work in different divisions, so we need to understand what goes on in the local county health departments where vaccines are being administered. I work at the local level also, and it's very, very, very helpful to me. My staff teaches me every day. But it's very important that we have primary and secondary persons that can be coordinators of vaccine. However this is accomplished in your counties, in your area, I think it's very important that it be specific and unique to the way you operate. And if you've seen one county health department, my stance is you've probably seen one county health department, because everybody does things just a little differently when it comes to their flow or their operations based upon the size of their building, the staffing that they have, etc. But again, have persons involved that are vaccine coordinators that can be aware of what needs to be done in terms of rotating the stock, in terms of taking expired vaccines out, etc. And again, the vaccine coordinators responsible for ordering, for inventory, rotating and returning the expired vaccines or a spoiled vaccine. And again, a spoiled vaccine, what I mean by that is a vaccine that's gotten out of temperature, spoiled vaccine that can no longer be used as a result of a temperature excursion. And again, we're all very aware of monitoring temperatures, and that's a topic for another day. But again, just making sure that we keep that product, that, as I go back to what the doctor said to me, if we don't give it right, it's not going to help the patient. So again, making sure that what we have is the product that we need to use for our patients. And also, it's appropriate to have the person's names on the refrigerator or in the room that's used for vaccines, so we know who to contact. I mean, I work in multiple counties. I've been in probably every county health department in the state of Alabama in my years of experience here. And I don't know everyone that works in the health departments. I know a lot of the people, but if we have the names on the refrigerator or the names in the room, we know who's responsible. We can locate that person. I was working a tuberculosis outbreak in Perry County, and when I first went into Perry County, I didn't know who Debbie was, but about 30 minutes later, I knew who Debbie was, and I knew that Debbie was the person I needed to go to. So it's very important to know who is responsible. These people know the counties. They know their counties. They know what goes on there. Incorrect vaccine administration. And again, this is an area that if we go back to our rights, we'll get it right. We had 6 incidents of incorrect vaccine administration in the past year. One was a situation where a child was under the age that was approved for the vaccine product. For example, the Kenrix product, it was approved for the 4-year of age group, and unfortunately this child received Kenrix, and they should not have. The second incident that was reported was a Tdap given instead of a meningococcal. Well, let's go back to looking at those vials, looking at those syringes. Person came in for meningococcal. That was what was ordered. That was what was on their imprint. That was what was on their record. They didn't come in for Tdap. So, again, give the right product. MMR given instead of varicella. And again, recognizing we're giving multiple vaccines at one time. I don't envy my nurses when I go out and say, this child is qualifying for numerous vaccines. I don't envy that. That is a lot of work for a nurse. And our nurses do a great job administering vaccine. But again, multiple products, we've still got to make sure that we pull the right products for the patient. And then, finally, a child receiving 2 vaccines, a combination vaccine with the same antigen. Again, go back to looking at your products. Make sure that you know your products, you know what products are recommended for that age group, and you administer those appropriately. And that's where the pink book comes in. That's where the protocol comes in. It's very, very important that if we're unsure about something, we consult with our expert resources. And then, as I remind people, you can always call me if you have a question. And short of my being on this videotape when Valerie Cochran's there with my phones, I'll answer the phone for you, or I will answer an email. So we also have other physicians that are available in addition to my being available for vaccine questions. Certainly Dr. Harris in Public Health Area 2, Dr. White in Public Health Area 3. But we answer questions for other areas of the state. And we're very happy to answer those questions. And if we don't have the answer, then we will find an expert resource on that. Now let's talk about the medical follow-up. Again, when we have an ARIA, when we have an incident that we have to report, we have to follow up with the patient, okay? There's a child less than 1 year of age that received an MMR and a varicella. Well, some of you may be saying right about now, well, I read, and, so I'm going to get a little bit ahead of you here. In outbreaks of measles, if we are working a measles outbreak, and certainly in countries where there are outbreak situations, you might see people getting an MMR after 6 months of age and prior to 1 year of age. And that has been done and is done in outbreak situations. However, it can't count. I mean, you can give it, but then at a year of age, you're going to have to repeat the MMR. So, again, a vaccine, an MMR given prior to a year of age, which might be appropriate in an outbreak setting, has to still be repeated after a year of age. Basically, it doesn't count as the first MMR. Now, in this particular instance, again, the child that received an MMR and also received a varicella, well, we had to follow up with that patient, ensuring whether or not that patient developed any of the signs that you might develop after having a measles vaccine or after having a chickenpox vaccine. I mean, we do know that some children will develop a rash, vesicles, or fever. Again, we're not going to do anything other than symptomatic treatment there, but we did want to know if this child had any signs of having taken the vaccine. And also the patient was instructed to contact their primary physician for any problems. And again, as I mentioned, the vaccines will not be counted. So the patient has to take them over again. And none of us, this is not something, as we're talking about opportunities for improvement, none of us is in a unique setting where this never happens in any other situation. But our goal with patients, regardless of whether it's vaccine administration, regardless of whether it's acting upon laboratory testing, regardless of whether it's prescribing an outpatient medication or treating a patient in a hospital, our goal should be to have no incidents or medical errors. It is a great privilege and a great honor for me after all these years in my career that patients allow me to treat them, that patients allow me to be part of their lives and part of their care. And we all take that charge seriously. So we want to have zero errors. We do not want to have an untoward situation with a patient. So again, what are our solutions? Well, again, certainly in this very short period of time, I can't provide every solution, but I believe if we go back to the rights, that in the instances that we have cited today, if we go back to the rights, if we follow our procedures, if we follow what we've been trained to do, that will significantly reduce or eliminate, in my opinion, eliminate these errors that we have had to occur. And again, reminding all staff that while we're going to have vaccine coordinators, we're going to have other people that are responsible for primarily ensuring that this vaccine product arrives correctly, is placed in the refrigerator correctly, is being rotated correctly, ordered correctly, etc. But all of us have the responsibility. Each and every one of us has the responsibility to ensure compliance with this. And as a physician and as the medical consultant for the immunization program, I take each one of these ARIAs and each one of these incidents, and I look at them to see how I might offer a recommendation as a physician in partnering and working with my nurses in the county health departments to ensure that our goal of zero adverse or ARIAs, if you will, are reported, because we can make a change here. We can do this. Additional suggested solutions, well, again, vaccine is much more complicated than it used to be. I know when I was a young medical student, another medical student used to give the lecture on vaccine because it's really pretty simple. There weren't that many products out there. But as time has changed, as we've gotten more scientific advances and more vaccines, it's become much more complex. And, it's a subject that's near and dear to my heart, and now it's really a specialty in and of itself, knowing about these vaccines. So we should review our schedules. The ACIP has a very colorful schedule. It's very readily easy to be followed, but also footnotes that are on there that are very useful. But we can verify and make sure we do give the vaccines appropriate to the patient's age. In addition, the vaccine forecaster is very, very helpful. And I'd also like feedback on that. Those of you that are out in the county health departments, please give us feedback on the vaccine forecaster, because we're trying to make this something that is a very usable and very friendly product for our nurses. And again, including in job duties to ensure compliance. I mean, I know in my career as a physician, worked with nurses throughout my entire career, and nurses have the same goals that I have. They want to do what's best for the patients. We all want to do what's best for the patients. So I think, it's good to include this in job duties, but at the same time, our goal is to provide the patients the best care we possibly can. Now, the Pink Book, we have the vaccine tables, we have information. The Pink Book is readily available. I have my Pink Book on my desktop, and then that way I can just go to it whenever I need to. We have the paper copies out there. And I'm a little old-fashioned. I do like a paper copy from time to time, but we can also have people to download the Pink Book, very easily done. Put it on your desktop if you need information from that. County Health Department solutions. Well, again, county health departments are where the action is, right? I mean, that's where people are taken care of, and that's where we provide the services. So some county health departments have packaged vaccine in bags or bins. They have the mailing labels. They have whether they're VFC or not. They put these in their refrigerator in a manner that is easily identifiable for them. Other health departments have recommended stickers on the refrigerator with vaccine funding explanations. For example, is it VFC? Is it county purchased? That's just another way to help us keep up with what we're doing. 6 months and above, flu vaccine, we have our PHIP. Again, it just many suggestions that have been forwarded by our county health department. So if you have a good suggestion as a result of this discussion today, please feel free to send that in. Please feel free to either email that in to Valerie Cochran or to the immunization program so that we can implement your suggestion and recommendation. Let's talk about adverse events for a few moments. And again, as I've already said earlier, adverse events from vaccine are exceedingly rare. And the vaccines that I'm going to mention here, the vaccine adverse reactions that we have here, are really not vaccine events that we would later reduce the vaccine schedule or would change the vaccine schedule or would not administer the vaccines again. But we want to know about adverse events because it gives us the opportunity to tease out what is or is not significant related to the vaccine administration. Now, last year we had a couple of Arthus-type reactions. These are not allergic reactions. These are reactions that one sees from time to time when persons receive antigens fairly close together. Now, I think it's interesting that while we had a couple of Arthus reactions from Tdap, we are now recommending Tdap for each pregnancy. And I have not seen an increase in reports either here or in scientific literature based upon giving those Tdaps much more closely together than we previously did. We didn't give we didn't give tetanus vaccine, less than 5 years. We didn't, 10 years or, 5 years if there was a significant wound. And now, again, repeating the pertussis, repeating the Tdap, we've not really seen an increase, and I've not seen anything, as I said, in scientific literature. But sometimes you do have an Arthus-type reaction, itching or pruritus, swelling, nodule, erythema. It does happen. And so I won't say that for the individual patient it's not something that bothers them, but resolves pretty quickly with anti-inflammatories and fluids. I could speak to the Arthus reaction again. I guess because I've been around in medicine a long time, I've seen a lot of different things. But one of my children had an Arthus reaction to a vaccine, so it does happen, and I was glad that I knew. I was glad I knew what it was. Again, I try not to practice on my own children, but you can't help but say, "Oh, that's what that is." So again, resolved, and both my children are fine now. The adverse events that we also have reported: syncope, dizziness, fainting, and fever. Well, again, when we give vaccines, sometimes we can expect syncope not as a result of the product, but who hasn't had a little needle phobia or heard of a little bit of needle phobia? And we do know that we see a little more syncope sometimes with the HPV vaccine. Again, how do we take care of that? Well, patients should not be standing when they receive vaccine. Patients should be sitting comfortably in a chair so that, we can take care of them if there is a fainting episode. Dizziness, that sometimes occurs. As I said, fever occasionally can occur with vaccine. These are not events that would preclude our giving vaccine in the future. But we want to know about it. We want to provide that information so that we have an opportunity to look at it. And we had a patient that had a swollen eye after receiving Hep B and Tdap. And I will have to say that I've looked at a lot of literature on this, and I've not been able to find anything that indicates that this is after a vaccine. But nevertheless, we took a report and reported this. But again, I've not seen this occur with vaccine, and I've given a lot of vaccine in my career. So what are our suggestions for reducing risk for adverse vaccine? Well, certainly we give every patient the immunization information, the VIS from the CDC, because we want the patients to read that. Should they have a very unusual contraindication to a vaccine, we want to be aware of that. In addition, we want to review all the available information on that patient prior to determining what vaccine they need. It's always important, and I'm very proud of what our nurses do in our county health departments, to have our emergency response kit available and keeping it readily accessible and readily in place and ready to follow our protocol. Again, I continue to be impressed with our nurses in rapidly assessing the patient, responding to the patient as the situation dictates, and ensuring that patient's health and safety. We have our emergency protocol. Our nurses are aware of that, and again, I'm very, very impressed that they're not only aware of it, but they implement their emergency procedure and they use it. This is extremely important. And finally, as I mentioned, following the protocol for adverse reactions and anaphylaxis. And again, anaphylaxis being exceedingly rare with a vaccine product. And hopefully I will continue my career without having seen an anaphylaxis related to a vaccine product. I've not had that happen before, so I hope that I won't see that. Certainly, we've got information about about completing the VAERS, and it's extremely important that we follow and complete the VAERS report for any adverse reactions. Now let's talk about notifiable diseases in the remaining time that we have left today. And this is segueing off a little bit about talking about vaccine administration and vaccine adverse events. But what I like to see is fewer vaccine preventable diseases because we give all the vaccines that patients need. So, if we obviously have a vaccine preventable disease, we have to report that, and it is notifiable depending on what disease, again, it is. And when we're talking about notifiable diseases, I have people ask all the time, well, who has to report notifiable diseases? Well, I think we're pretty much at the point that if we think we have a notifiable disease, we report it, and if it turns out not to be something we need to act upon, then, that decision will be made. But certainly, if we receive information, front desk, we get a phone call, someone says, my child has measles. Well, we're going to send that information. We're going to send that call back to the back and let the nurses take that down, let the immunization staff take that down, again, depending on who's in the health department, take that information and find out what's going on. Most of the time, they don't have measles. In fact, in our last case in Alabama was an imported case, actually a person that was on a ship that came into Mobile, and we've not had a case of measles other than that in Alabama in a number of years. But again, why do we have notifiable diseases? Why do we need to even do this? Because there's an opportunity for public health intervention. Okay, there's an opportunity for us as a health department to make a difference in the health of the population or the health of that individual. So sometimes we receive information that is redundant. We receive, oh, did you hear about this? Did you hear about that? I currently have a notifiable disease from a hospital that is an unusual disease. I think now that 12 people have personally reported that to me. But you know what? I'll take it, because I would rather have 12 people report this very unusual disease to me than no one to report it to me. And then guess what? It's a notifiable disease that we had an opportunity to intervene, and we we're not able to intervene. For vaccine preventable diseases, again, immunization homepage, we have the information there to report. And of course, good old paper copy, I think all that's going away anyway. But again, how do we report a notifiable diseases, and what should be reported? Well, we have a list of notifiable diseases. It is on the website. I'm pretty sure most people know that if we have certain notifiable diseases, those are 4-hour diseases. Then we have our 24-hour diseases, and then we have, 7-day diseases. But again, we have our 1-800 number. We need to be called for any 4-hour diseases. Our 24-hour presumptives, also call the 1-800 number, or complete the report card. And then, of course, the 5-day standard VPD. That's very, very important. And again, an opportunity for us to intervene if we need to. Now, I get asked this all the time, primarily by hospitals and other physicians. Well, I can't report that anymore because of HIPAA. Well, that does not apply when we're talking about notifiable diseases. Again, that does not mean that we're not going to protect the patient's confidentiality, because we are. We're always going to protect the patient's confidentiality. But a physician, a nurse, a laboratory, other groups of persons that receive information regarding infectious diseases in their patients, or again, laboratory reports, many sources, that needs to be reported to the health department, and again, it needs to be reported to us quickly in order for us to intervene. There is a HIPAA letter, because many people had this question, and we're able to provide the information that shows that we do not have to have patient consent in order to receive information on notifiable diseases. Okay, well, I have completed my section of the discussion of vaccine preventable diseases. Valerie, let me ask you, do you want us to take questions at the end of the session today? Is that the best way to do this?
I think that's a good idea, Dr. Landers. We don't have any questions right now, but I would like you to comment on anaphylaxis, which, that's one of our favorite subjects, that and flu. But, nurses seem to be afraid to administer epinephrine. Mm-hmm. And according to our protocol, which you wrote actually, you never give the Benadryl without the epinephrine first. And I would like for you to comment on that.
Okay. And again, in our talk today, obviously, we'd like to provide a lot of additional information. Our time really precludes my going into an extensive discussion of anaphylaxis. But from our protocol, which is based on expert guidance from the persons who do research in this, the American Academy of Allergy, Immunology, a very, very scientifically based group. That information comes from much research, and it also is in the Pink Book regarding response to anaphylaxis. And what I remind persons is that if we have signs and symptoms of anaphylaxis, failure to intervene, failure to provide epinephrine and then Benadryl to the patient, epinephrine being the most important, has been associated with mortality. And I stress that because there are situations where persons, again, are afraid to go ahead and give the epinephrine. They feel more comfortable giving the Benadryl. And the studies have shown, and I believe I may have it in my anaphylaxis discussion that we have online, the epinephrine works, very, very quickly. I mean, just within, seconds to minutes, whereas Benadryl takes, a number of minutes or even longer. And steroids, which, that's everyone's favorite go-to nowadays, that's hours later, and not even a lot of good data on using steroids in anaphylaxis. So I stress to persons in following the anaphylaxis protocol, if we have a patient that has signs and symptoms consistent with anaphylaxis, based upon our protocol, we should go ahead and proceed with the epinephrine first, and then give the Benadryl. And as part of this, we're going ahead and intervening and calling our emergency provider. We're calling for 911. We're calling for backup support. But to delay giving epinephrine even over several minutes can allow the opportunity for that cascading effect of the anaphylactic reaction, and we just can't reverse it. And I think that one other thing that points this out is now the widely available epinephrine auto-injectors. Now, there's a product, and of course we showed one product in our EpiPen protocol, and again, EpiPen is the name of a product, but there are epinephrine auto-injectors that are generic. So I'm not endorsing a product that just happens to be a commonly used product, and also a product that has gotten a lot of press lately. There's nothing wrong with the epinephrine auto-injector. There was a lot of discussion based on cost, but I think there have been some discussions more recently that, there are some less expensive alternatives. But nevertheless, to get back to, if we, as the general public, are now prescribing auto-injectors to persons who have risk factors for anaphylaxis, to self-administer and then go to the emergency room, and we're providing it in a dual pack so that not only will they administer, but they'll also re-administer based upon their signs and symptoms while they're in the process of getting to their emergency provider. Then if we're training the lay public to do that, then, we as physicians and nurses, we have more training, we have more skill in assessing and evaluating a patient. And the harm is in not intervening for the patient. So anyone that has additional questions about that, and I hope that answered it, Valerie, anyone that has any additional questions can do two things. One, I'm certainly happy to talk with anyone about it, but also I think the epinephrine auto-injector program that we did for the lay public is very informative. I always learn a lot doing these things myself, and this is something that I've had a great interest in anaphylaxis for two reasons. Number one, I was at the University of Tennessee. That's where Dr. Phil Lieberman, who is author of much of the information, is located. In addition to that, I had a relative to die as a result of anaphylaxis. So I think it's extremely important that we remember that we as doctors and nurses have this information. We can assess the patient. We have a protocol. We need to follow that protocol. And also we're training the lay public to do it. So if we're training the lay public to do it, then again, we bring a higher knowledge base to that. So we should not delay if a patient meets the signs and symptoms that are compatible with that. So did that answer you, Valerie? Thank you very much. Any other questions from the audience? If not, this might be a reasonable time to take a 10-minute break, and then we'll return to Betty Helms' discussion. Thank you. Welcome back to the Alabama Public Health Training Network. As the second portion of our program today, we're delighted to have Betty Helms with us Administration Branch Director for the Immunization Division. And Betty's going to talk with us about ordering state-funded vaccines. Betty, welcome to the program.
Thank you, Dr. Landers. I enjoyed what you were saying a few minutes ago, and it kind of helps keep my perspective when I'm doing grant writing and stuff of the things that our nurses are going through. And I'm just going to add a little bit more to you and the office staff today. And it's not going to be that bad. It's not anything you're not normally used to doing. But starting October 1 of this year, we're going to give the county health departments money, and they will be ordering their own state-purchased vaccines for your insurance billing. This is nothing to do with the VFC vaccines. This is strictly state-purchased vaccines. We're going to have you order your vaccines through Amerisource, utilizing the Minnesota Multi-State Contracting Alliance for Pharmacies, which is called MCAP, because that's where our pricing is. The Attorney General in 2003 issued an opinion stating that the MCAP is a sole source for vaccine purchasing, and then we were exempt from having to do the state bid process. If we did not have MCAP in place, you would have to go through quotes from the different vaccine manufacturers, and this really made it a lot easier on us in that it is a declared sole source, that now you can just go to Amerisource. Amerisource was listed as the source for us to buy these from. So you're familiar with it right now with family planning, and it is our vendors. You don't have to worry about the state bid laws of only $14,999 before you had to do the bids. So some of you, most of you will be spending more than that with the vaccine purchasing. The benefits and for the county health departments and ADPH, we have really met on this and discussed it of what is some of the things that would really help with our vaccine purchases. And there will be decreased distribution expenses for the department. That's staff time, warehouse space, heating, cooling, maintenance, UPS shipping, the shipping supplies, ice packs, the coolers, the boxes. That really adds up. So those will be eliminated because Amerisource will be shipping them direct to you. The county health departments now will be in control of their vaccine presentations. If you want multi-dose vials, you can have multi-dose vials. If you want the syringes, you can have syringes.
Debbie, can I say something to that? We have, there is a policy that this department uses retractable syringes. They need to take that into account, and also the storage space involved with single dose. We love single doses. They are easier, but you've got to take into account the safety device, and we have found that retractable needles cut down on needle stick injuries to nurses. So just take that into account when you're ordering.
Okay. Thank you, Valerie. I'm an accountant. I am not a nurse, and y'all better be happy of that. Also, the county health departments will have the ability to be a little more flexible. If you want to start an adult program, you can start doing the adult programs. Right now, because vaccines are so expensive, we haven't been able to do that, but it may be something that you as a county or an area decide you want to step into, and this will allow y'all to do that. We have a lot of people say, well, why can't I give Tdap to this parent? Well, it's because we did not have a protocol for it, because we didn't have an adult program. This will allow y'all now to get into this. you're going to have less refrigeration space out there. So hopefully you won't have to buy as many refrigerators because you're not going to have to order for 3 months. You're going to order basically probably once a month, but if you ran out of something, usually within 2 to 3 days, you can have the vaccine in hand when you order it from Amerisource. We really feel like that this will help y'all out there and you won't have as much spoil. We also will be getting an increased share back from Amerisource. This is basically where we get a discount. The more we buy from Amerisource, the more discount they will give us. So the county's beginning to purchase the vaccines from Amerisource will help the department as a whole, and it's going to reduce our cost and our future purchases. The vaccines can be ordered when supply demands. You can go ahead and say, it's back to school time, and it's what in your month. Well, now you can wait and get it, but make sure you don't get to where Amerisource doesn't have any vaccines. So you're going to learn these things. You're going to learn the time. When do I need to do this? You will no longer be having to take time for the monthly inventories to be gathered by the nurse and sent up to central office. So that should save the county health department some staff time. Now, you're still going to need to do your own inventory. Don't get me wrong there, but yes, you're not going to have to take the time to get it into Montgomery on our form, but you are going to still need to make sure you're watching your vaccine expiration dates and how much of each item you have. We're thinking that this will also help you move closer to being like a private provider. More and more, the county health departments are going to have to do that. We're looking at the electronic health records that private providers use. We're getting more and more to that standard, and we're thinking this is going to help you because you will be doing, as the private provider, you will be ordering your VFC vaccine. You will be ordering your own private stock. The ordering procedures from now until the 1st of October, the county health departments will use the purchase order number that I've already sent you, which is 3522138. That's for Amerisource. Order your vaccines in, then come back when the invoice comes, use the fund code, and I don't see that up here, FB 1150099. The object code is going to be 0901. Cost center is 065. 065 is the cost center for clinic, immunization clinic. And then you'll use site code 700. Do not use your county site code for now. After October 1, yes, you will, because it will be on your county purchases. I got to go back one. After October 1, you will do your own purchase orders. But for now, it is our purchase order for the immunization division. You can send it to me, Betty Helms, Suite 1486 at the RSA Tower. Working through finance with this, it was decided that I needed to approve them to make sure my funds weren't overspent. So send your invoices in to me. You can go ahead and fill out the fund codes, any authorization that you may want from your local county health department, but send it to me. I'll approve it, and then I'll send it on down to finance and hopefully get it paid. They're a little slow sometime down there. The ordering procedure after I'm just losing it right now. After October 1, the process is no different from the current ordering for family planning and STD drugs. Currently, the county health departments have Amerisource purchase orders for family planning 340B drug account. You have it for the STD meds account. And then you have a clinic, all other general or miscellaneous account. Some different counties call it different names, so it's mainly your clinic, all other. I think I got more from people talking to them on the phone. The ordering procedures, your vaccines can be purchased on the Amerisource General Clinic account, or the county health departments may want to create a vaccine account. They will pay their own invoices through Health Finance for vaccines purchased in FY 2017. Make sure that you order enough before October 1. We can still order vaccines because it is medical. Look between now and the end of September and order enough to get you through October, because we're starting in the STARS system October 1. We don't know how long that's going to take us to get the purchase orders through. So kind of anticipate what you're going to need. Go ahead and order it while the immunization division's paying for it. And that way you'll have it on hand, because the purchase orders may be slow coming out. We're just really not sure how that's going to work because of the new STARS system. But we also have inventory on hand that you can use right now. If you want some of those supplies, you'll send the orders by email to immunization@adph.state.al.us. And you will call Amerisource to place your orders. Amerisource will be stocking the vaccines required or provide it within 10 business days to you. So that should be a good source. The county health departments can order vaccines when the inventory runs low. There's no need now for you to have to wait a month or at the quarter end or whatever, the different places. Now, VFC vaccine, you will still have to do it monthly. But state purchase vaccine, it's when you need it. But be sure that you order enough vaccines so that the county health departments don't run out. But don't order so much that it's allowed to spoil or expire, because some of you, I have gotten a few phone calls already saying, wow, we didn't realize vaccine costs so much. But we really thought this would help give you some ownership into the program. You can not borrow VFC vaccine. If you run out, you've run out. Order it. Get some more in. The things I've ordered from Amerisource have come in very quickly. And looking from the purchase orders and the invoices that's already been sent to me, most of them are getting things in within a day or two. So watch your inventories and make sure that you distinguish between your VFC vaccines and your state purchase vaccines in the refrigerator. A good other way of noticing is that your VFC vaccine will still be coming from McKesson. It's going to be just like you're used to seeing it, but your state purchase vaccines are now going to be coming from Amerisource. But if you need, we do still have some of the stickers for VFC, and we do still have stickers saying state. So if you don't want to keep a state sticker later, if say you don't want to keep up with that, as long as you've got it on the VFC and we know it's VFC vaccine, that's what we're concerned about, is what is the VFC vaccine. Anything else is county if it hasn't got the state vaccine on it. You may not can see this real good. If you will go look on the where you registered for the program, they do have this slide. It is the vaccine inventory out at the warehouse that was effective on the 9/8. There may be a dose or two short, but for the most part, these are the vaccines that are on hand. And if you'll just let us know, those are no cost to y'all. Just let us send an email and we can go ahead and ship those out to you. Vaccine ordering continued. Let's go. Flu vaccines must be pre-booked. In February or March each year, we pre-book flu. So you're going to need to think about that. I will be giving you another set of money for your flu vaccines, and we'll base it on what was ordered this past year. But you will need to reserve those, so do think about that. That's something we do usually up at central office, and then the vaccines don't come in until, well, it's coming in right now. We encourage you to stay with the current vaccines on the encounter forms. Some of that's because it's things we're used to. It helps match what we're getting from the VFC program, and it's the vaccines that are in Falcon in the drop-down boxes. If you do order something and it comes in and it's not on the encounter form and it's not in Falcon, send us an email to the immunization at adph.state.al.us, giving us the vaccine name, the manufacturer, the vaccine brand, and the NDC code. That will allow us to get it into Falcon. Now, it's not quick getting it into Falcon, but it will allow us to get it in there. So just as soon as you know you've got something else, let us know. You need to pay attention, real close attention, to how the vaccine is packaged. We've had some that's had a big surprise this week when they thought they were ordering 30 doses and they got 300. But we worked through it. So be very careful, because some of them are packaged in boxes of 5. Some of them are in boxes of 10. Like Tdap. Tdap's packaged in 10 one-dose vials. So if you ordered 4 boxes, because most of the time you're going to order by the box, you're going to have 40 doses. But if you order 40 thinking you're ordering 40 doses, you've now got 400 doses. Same thing with Active. The packaging is 5 one-dose vials. If you order 4 boxes, I've got 40, but it's supposed to be 20. Or if you order 40 boxes, you're going to get 200 doses. So if you need assistance with AmeriSource, if you've got a product problem or something, contact Nancy Bishop, who is our acting state pharmacist. And you can get her at 206-3014. And if you haven't worked with Nancy yet, she's real easy to work with, and she's helped me a lot through this with AmeriSource, and I appreciate her. The vaccine funding. Immunization's going to provide y'all some funding. We're not just going to throw you to the wolves, but we're going to base it on vaccines that were administered from 7/1/2015 to 7/1/2016. Another fund source will be used for the flu vaccines, and it's not included in this first monies that we're going to give you. But beginning 10/1/16, the insurance, vaccine, and administration rates that have been collected will start going to the county health departments on what you gave. Those have been just going what we call the big black hole, which is finance, but we're about to start putting those back out, and they will come directly to you. Now, be aware that these vaccines are anywhere from 9 months, 10 months behind of what is taking place right now. So you're not going to get it, or, the shot given, it turned in. There is some delay. We have talked with IT on this, and they have assured us that they feel like they could get this going a little quicker, because we know the counties need to be checking back to see, have they been paid? Have they not been paid? Why didn't it get paid? Well, it hadn't been billed. Or, oh no, we did the wrong thing here. We didn't really mean we gave this. We gave something else. So the county health departments will also continue to receive the $8 administration fee for VFC vaccines for Medicaid. Y'all are already getting that. So, but you will still continue to get that. We're not doing anything with that money. This is the funding is based on MCAP pricing. If you're having trouble with this one, it is also in the package at the beginning. But when you look at this, it's based on doses given. The first one is a DTaP. This county gave 4 DTaPs from 7/1/15 to 7/1/16, or that's what they put into Falcon as state purchase vaccine. So if they had the 4, MCAP pricing was $19.51. We were going to give them $78.04 for that. So this county, when you look that this is the number they gave, 241 shots is what they gave during that year. The funding for that would be about $15,000 that we will give you to start with, to where you can start your own vaccine purchasing. I think that somebody asked me earlier, they did call, they said, Betty, what do you mean that it's $78? Well, I said, you got to look at the number of vaccines. It's the doses administered is the key there. But beginning 10/1/16, the vaccine and administration reimbursements will be given directly to the county health departments. This will allow the county health departments to follow the funds from vaccine purchase, administration, and reimbursement. When the EOP arrives, the staff will be able to determine if the correct amount was billed and reimbursed. The administration reimbursement rates are antigen-based, An antigen refers to all the individual antigens in a vaccine. It's a combination vaccine, your DTaP, your Tdap, you have to look and count the different vaccines that's in there. It's multiple antigens. This chart goes through and it lets you know that if it has one antigen, you get $21.61. If it has 2 antigens, you get the $21.61, but you also get $10.50 more. So according to the vaccine you get, you could be up in the $60 or so just for the administration part. Now, Blue Cross is going to pay you for the vaccine, but then the administration is separate. So you need to come back and check. Sometimes you'll see on your EOPs that something didn't pay. Well, why didn't it pay? Well, that's when you start looking, it might be that they didn't do enough antigens. They may have added too many antigens, but make sure that they do it by the antigens. Reimbursement examples. On your Blue Cross Blue Shield, it's important to follow up with your EOPs. Again, I used the counties from before that had they administered 4 DTaps. The vaccine rate per dose is $19.13. The administration rate is $42.61. So the reimbursement rate, if you got 100% of them, is $246.90. But if you only collect for 75% of them, you're not going to get but $185. So you really want to follow those EOPs to make sure you're getting enough money, because you're going to be using this money to order more vaccines. And it also helps pay for staff. If you have expired and spoiled vaccines, follow the manufacturer's vaccine return policy. The vaccine companies all have their own policies, and that's how you will return the vaccines. Now, if you've used part of a vial, most vaccine companies will not take that back, but the whole vials they will take back. Do not send it to the Mitchell Young Road warehouse anymore. If it's VFC vaccine, you will still continue to return it to McKesson, because some of the manufacturers will reimburse the cost of the vaccine and the excise tax. But some will only do the excise tax, which is 75 cents per antigen. Again, remember the per antigen. So it's 75 cents plus 75 cents plus 75 cents, according to the number of antigens that you get. All of our clinic staff will be involved in vaccine, must watch the You Call the Shots and vaccine storage and handling on the CDC's website, and we've given you the web page. There are free CEUs and CMEs for watching these resources. In addition to You Call the Shots, there's also 13 other immunization-related programs that's available through CDC. Another thing that we are going to give y'all money for is one entry-level staff nurse per the new districts that will give the salary and fringe for 2 years, and that's right around $125,000 for the nurse. The RNs will be able to assist the districts, county health departments with immunization-related activities, for example, vaccine ordering, vaccine inventory, vaccine administering, returning, and the expired and spoiled vaccines. What this person can do for the areas will determine this, but these are just some of the activities that we feel like they will be doing, because our area immunization managers now per our grant are doing other activities. So this is going to allow the counties to have somebody that they can count on to help them out. EFIX is the IT explanation of payments, or the EOPs, that ADPH has, and they will be designating one person in your county for this. Most counties may already have this, but they don't have it for the vaccines. You'll check your EOPs to ensure that all the vaccines administered to patients have been correctly billed and reimbursed. And if there's a discrepancy, you can contact the ADPH billing unit at 206-5233. I've given you a picture of a current EOP, and it's in there telling you that here was the first dose he had, this was the second dose this person had, and they collected. Well, if you look on down to around line 7 or 8, it's in there denied, denied, denied. Well, why was it denied? The counties are going to be the ones looking up why was this denied. It could be that when you were in Falcon, you hit the wrong NDC code. So it looked like you gave a 6-year-old a dose that should have been given to a 40-year-old. So little things like that, it could be something simple, but insurance isn't going to pay it because you put in the wrong code. Or it could have just been somebody in the billing department that turned in the wrong code. It could be something that simple, or we just have to find out what is it, and it's going to be up to the counties to follow this. This is the sample screen for eFix. Some of you may be familiar, some of you are not, but they will give you a login and a password for your eFix. Your accounting and your distribution. Insurance is a third-party payer, so the county health departments are going to be responsible for ensuring that the reimbursements are distributed to the proper accounts. I've talked with Health Finance, and you're going to need to work with them to set up an account for the vaccine reimbursements. And you can contact Finance at 206-5233. The vaccine cost reimbursement must be placed in a separate account, ensuring that the funds are there and available for future vaccine purchases. And this will assure the sustainability of the vaccine program in your county. According county and distribution, also we have that the county health departments want to expand their vaccine programs. They will probably have to use some of the vaccine administration reimbursement in addition to the vaccine reimbursement, because that's going to show up on your EOPs as two separate lines. And I'm going to leave it open for questions. I know I threw a lot at you, but if you need me, you can reach me at the towers at 206-2045, and I'll be glad to help you in any way I can as we work through this change.
Betty, I've got a couple of questions.
Okay. I'll try.
Can they use this money for international travel? If they've got a good clinic going and they can bill Blue Cross and Blue Shield for international travel, can they use it for that?
No.
Okay.
This is strictly for the county's health departments, unless their international travel is part of their regular clinics.
Well, I think, they decide whether they want to be a clinic site or not.
Okay.
That's just the big counties have done it, but it might be something they could think about. I don't know. And we no longer give 317 vaccine. Is that?
It's not that often anymore. This time we used our 317 for PI planning.
Okay.
So it has to be underinsured that get the 317.
Okay.
They've put more restrictions on it than what it used to be.
Okay. And I
And
got
I
one
hadn't
more
got
question.
that written down to give you the exact.
Okay. You're doing good, though.
Influenza.
Yeah, we did pandemic influenza with it this year.
Okay. Pre-booking flu. Are y'all going to tell them how to pre-book flu?
Yeah, and it's not that hard. I do it. So I know anybody else can. They'll just go back through Amerisource and tell them, okay, and it's usually February and March. And they usually will let us know, so I will see if I can get with Amerisource and just see how they want it done. But usually you tell them this, I want 500 doses of this, and then come time when they have the vaccine available, they'll ship it on out to you.
I think the main question I have is, how are they going to know when they're supposed to pre-book? Is Amerisource going to say, we're pre-booking now, or are you going to tell them?
Do you know? I don't know that one because I don't usually order through Amerisource, usually the vaccine reps would tell us it's time to pre-book.
Can y'all take that on and find out how they're going to know when they're supposed to pre-book?
Yes.
Because if we don't tell them, they're not going to pre-book and they're not going
Yeah.
to have flu vaccine.
And I'll be glad to help with that. But that is one that I really have not worked with Amerisource yet, so on that one. Do you know?
It also can be done through MCAP, and I'll be glad to send the notice from MCAP to the area nursing directors.
Okay.
Okay. There are no questions coming in by email.
There's a phone call coming in from Hale County.
Hello?
Yes, I'm here.
Okay.
Good, great. Thank you. What is your question,
Are you ready for my
please?
question?
Yes, uh-huh.
Yes?
We're ready.
Yes.
We're ready.
Yes, I was calling because you said you cannot borrow VSC vaccine. Does that mean only you cannot borrow VSC for a state, or you cannot borrow VSC from county to county?
From state, and this should have you, because you're allowed to order your VFC vaccine monthly now, you should not be having to switch it from county to county. You should have probably less in stock now because you're ordering it monthly instead of quarterly. So this should get that down, but no, you cannot ever borrow VFC vaccine in lieu of...
Okay, so you cannot borrow from county. Say if you needed something for that day, you cannot borrow from one county to the other.
I guess if somebody's going to have to go get it for you to borrow it from one county to another.
Correct. Yes.
But usually they don't want you to transport vaccines. And your area immunization manager will no longer be doing that for you. It's going to be more this county area person that you would have to contact on getting stuff moved around, but it's still the normal storage and handling procedures that you would be following. But never borrow a VFC vaccine because it has to be paid back.
Did that
Kind of
answer your
fading in
question?
and out.
Did that answer your question? Did that answer your question?
I didn't hear part of that answer.
Betty, would you repeat the answer regarding the VFC? I think we need clarification for VFC versus state, and also VFC from county to county in perhaps an unusual or an emergent situation. So would you mind repeating those answers?
If it's an emergency situation, you may be able to, but transporting vaccines, you have to be very careful on the storage and handling of it. So it's really frowned upon to move it from place to place. If it is an emergency, I would guess you would have to, but you cannot borrow the VFC vaccine. That's the point we're making, is I don't care if you've got VFC vaccine in the refrigerator, you cannot borrow it for that patient.
If it's a state, basically
if it's a state patient.
State purchase.
Yes, I understand that part of it. Yes.
Okay. Any follow-up to that question? We have another call from Elmore County, unless you have another question. Okay.
Hello?
Go ahead, Elmore County.
Yes. My question is, I know we're doing Blue Cross Blue Shield billing and Medicaid. What about the other insurances such as TRICARE and United Healthcare? Are we still not able to bill for these insurances?
We still want you to continue to add that information into Falcon, but right now we're not billing those. And we're even trying to see, is it feasible to bill for those? But do enter the information, because if you don't let us know, I've got 10 patients or 50 patients that have TRICARE, we don't know that we need to push this, because it does take a while to get our doctors credentialed. It's not cheap to get the system set up that these health insurers want for us to be able to bill them. So if it's something like that, we don't know. Some of them we can try to bill, but right now it is still strictly Blue Cross Blue Shield. But I know we're back in the market again looking at United Healthcare again right now, trying to see what we can work out on it.
Okay, thank you very much.
Thank you. Do we have any questions from email, Valerie?
No, ma'am.
Okay, any questions from the audience? Yes.
About the reimbursement. I just have one statement about the reimbursements for the vaccine. The manufacturers, most of them will give the full amount if it's expired, but only the excise tax if it is spoiled. So if the expiration date is coming up, it would be better after it expires to return it.
Thank you.
To get the most of it.
Thank you, everyone, for participation today. I don't think we have any other phone calls, and we have no other email questions and no other questions from the audience. Again, we would like to encourage anyone who has questions that come up later, call us, give us an email on that, so that we can all continue to work together, because our goals, as we talked about today, are to reduce the risk of, or reduce the situations where we had areas. We also want to provide information about vaccine adverse events. We want to provide information today about reporting of vaccine preventable diseases, and also encourage the county health departments, as we are launching into this new initiative where each county receives its own money for vaccine programs, for you to be able to address that confidently and competently. And we're still here to work with you. We're not going to, just put this out there and say, okay, here, you do this. Betty is an expert on this. I've worked for a long time with Betty on all matters related to vaccine and billing. And again, she has a great wealth of knowledge on this, and certainly she'll be happy to answer any questions that you might have. So again, thank you very much for your participation today. We appreciate your tuning in.
Thank you.